Two patients present to a clinic with identical, severe clinical complaints of insomnia. Both report an inability to initiate sleep, frequent nocturnal awakenings, and profound daytime fatigue. Relying strictly on these shared subjective labels often leads to the same diagnosis and the same standard line of therapy. Often, this generalized approach results in clinical failure for at least one of the patients. The failure occurs because the shared symptom is an illusion. Beneath these identical clinical complaints lie radically different underlying biological and physiological data geometries. Patient A suffers from a structural breakdown in sleep architecture, while patient B experiences a molecular chronobiological misalignment. In modern sleep medicine, generalized categorization is obsolete. Precision treatment now demands high-resolution clinical phenotyping to isolate the specific mechanism causing the dysfunction. Achieving this level of resolution requires a multi-omic diagnostic matrix, an integrated approach that combines data from multiple biological levels to form a single profile. This matrix builds a complete patient profile by layering three distinct diagnostic streams: baseline subjective instruments, objective physiological monitoring, and highly specific molecular biomarkers. Without integrating all three layers simultaneously, clinicians treat a symptom cluster, while the actual biological driver remains unaddressed. Construction of the diagnostic matrix begins with the necessary frontline layer, subjective screening instruments. This 2D radar chart maps a patient's self-reported baseline using three standard scales: the Pittsburgh Sleep Quality Index, PSQI, which measures perceived sleep quality, the Epworth Sleepiness Scale, ESS, which assesses daytime sleepiness, and the Insomnia Severity Index, ISI, which tracks insomnia severity. These scales establish the patient's perceived severity and provide a baseline to track clinical outcomes throughout the treatment process. However, subjective scales provide the what without the how. They lack mechanistic insight, meaning a patient can report profound exhaustion without revealing why the physical process of sleep is failing. Actigraphy serves as the bridge from subjective perception to objective characterization. This process involves using non-invasive wearable sensors to measure movement patterns and light exposure over extended periods, usually 2 weeks. Extending from our subjective baseline, this actigraphy scatterplot maps 14 days of longitudinal data. It quantifies the regularity of the sleep-wake rhythm and the actual total sleep time by tracking when the patient is physically active or still. Observing these movement patterns reveals the specific degree of sleep fragmentation, the frequency and duration of awakenings that occur in the patient's natural environment. While actigraphy provides longitudinal movement data, it still leaves a critical diagnostic blind spot regarding the brain's actual structural sleep architecture. To map that structure, we use the neurological gold standard, polysomnography, or PSG. This comprehensive overnight study precisely records brainwaves, heart rate, and muscle activity. A standard PSG study targets specific quantitative metrics, including sleep onset latency, the time required to fall asleep, and arousal indices, which log the number of neurological awakenings per hour. This 8-hour PSG hypnogram visualizes sleep stages. Overlaying it isolates pathological markers movement sensors miss. A red box targets REM sleep without atonia, where the brain enters active REM, but the body fails to induce the normal muscle paralysis, keeping the sleeper still. Identifying this specific physiological feature leads directly to a diagnosis of REM sleep behavior disorder. This physiological data confirms that the brainstem is failing to inhibit motor neurons during the dreaming phase. The initial subjective complaint of poor sleep now has a clear physical cause. PSG successfully maps the structural breakdown of sleep. However, this remains a structural map. It cannot explain the chronobiological or metabolic drivers causing that structural failure. To identify those drivers, we integrate the final layer of the diagnostic matrix, molecular and chronobiological data. This involves mapping the patient's precise circadian phase, the internal timing of their biological clock, using hormonal markers. Tracking cortisol secretion rhythms helps clinicians differentiate between specific circadian rhythm sleep-wake disorder, or CRSWD, phenotypes. Intersecting graphs map cortisol and melatonin secretion. A glowing node pinpoints dim light melatonin onset, DLMO, the the most accurate marker for the internal night. Beyond hormones, the matrix incorporates metabolomics, studying small molecule metabolites and genetic influences. Specific lipid species and metabolites correlate directly with insomnia and circadian disturbances, acting as indicators of the patient's internal metabolic state. Altered expression in clock genes provides a mechanistic look at the disorder. These alterations show that the sleep disruption originates during DNA transcription rather than appearing as a secondary response to stress. Layering these molecular targets over the physiological and subjective data transforms a generalized diagnosis into a high-resolution biological phenotype. The entire diagnostic workflow culminates in the collapsing of subjective, macrophysiological, and molecular layers into one unified profile. This synthesis produces a distinct clinical phenotype, defining the patient's condition as a mapped biological entity. The distinction is vital for treatment. For example, clinicians can now separate standard insomnia from the specific phenotype of insomnia with objective short sleep duration. Isolating this specific short sleep phenotype using PSG and metabolic data alters the entire therapeutic calculus. Identifying objective short sleep duration informs tailored behavioral and pharmacological therapies that would be ineffective for other insomnia types. Similarly, accurate circadian assessment via the DLMO marker dictates the precise timing for phase-shifting strategies, such as light therapy or melatonin administration. Modern sleep diagnostics demand comprehensive evaluations to capture diverse manifestations and guide targeted interventions. By embracing the multi-omic phenotypic matrix, clinical sleep medicine achieves true personalized intervention, directing the right therapy to the exact biological mechanism.